Good morning. Welcome to another week's of critical appraisal session under short course in clinical epidemiology. So this week we are happy to have Dr. Anuka for the first session on critical appraisal of cross-sectional study. So previously we have had one session on using CASP questionnaire, but we also have the Strobe checklist, which is a reporting checklist for any cross-sectional study, which is for observational studies. But there is one specific for cross-sectional study, which is a slight modification. And for all the observational studies, there are minor modifications for each one of those observational study designs. So Dr. Anuka will be going through one such paper using the Strobe checklist for a cross-sectional study. And without any further delay, I'll hand over to Dr. Anuka. Thank you.
Good evening, I'm Anuka. I'll be doing a critical appraisal of a cross-sectional study. Today, I'll be using the Strobe checklist, which is a reporting checklist given for observation study. These are the levels of evidence in medicine. And if you look at observational study, that is one of the second level from down. So we will be talking today about observation study, one of that, which is a cross-sectional study. There are two types of observation study, cross-sectional or a longitudinal study. The difference in a cross-section, the data is at one point of time. So the collection happens at one point of time, but for a longitudinal study, that doesn't work. The same population or same group is followed up over time. And in a cross-section study, the data is collected, can be divided into cases, controls, and looked at the multiple exposure. So this is the same thing. Data one sample and groups can be compared. Longitudinal study, repeated collection over a time. So what is the advantage of cross-section study? It is a cost-effective study. The data is collected very quickly. There is a snapshot of the population. So the snapshot of the population actually equates to the prevalence of whatever parameter study. Can look at the trend and look at multiple factors. Now the disadvantage is it cannot measure incidence and cannot look at a behavior or a long-term trend because we are not following up the people. Now, because clerks are supposed to be there, something about incidence versus prevalence. So prevalence is a proportion of people who have condition at a given time. Incidence is number of cases at a given time. So if we look at a diagrammatic representation of that, the prevalence is at a given time, all the cases, that is old plus the new. But incidence is only the new cases which are there at a given time of prevalence. So we had very good visualization, data visualization classes. So this is one graph which x-axis shows time period, and this looks at the number of cases. The blue line is new HIV infections, and the red line active HIV or AIDS infection. So which one shows prevalence and which shows incidence?
Is incidence, it is prevalence. You are right.
So incidence. So this graph looks at HIV infections, number of patients with HIV infection. The blue line shows a new HIV infection over the time, and the red shows the total number of active HIV infections. So which one shows incidence and which one shows prevalence? Excellent, yeah. The blue is incidence because it looks at the new number of HIV. But red is the prevalence. If you look at over the time, the incidence has actually come down after the medicine. But the prevalence, because the new and the the prevalence has gone up. So this is usually seen in chronic condition, but in acute or a very short condition, both might be similar. This is similar, another study presented in Lancet. So if you look at the based on gender, both has come down. Even the deaths has come down with ART. But the prevalence, because of the active existing HIV infection, it has gone up. Normally, cross-section study shows prevalence. Normally, the cross-section, if you look at one-time data, it does not collect incidence. So now we come to how to report a cross-section study. This is a checklist I have taken from the EPIDEMIOLOGY network. It is online, it's free. If you go to the website, there are different guidelines for different study types. The observation study Strobe checklist. It also, you can even search based on your studies, it will tell you which type you can choose. So I have taken Strobe, and for Strobe, there is combined cohort case control and cross-section studies, and I have chosen the one for cross-section study.
It's not AI today, it is Chrome checklist. No problem.
Before we go to the paper, we go to a clinical question. Suppose you have been appointed as an advisor to the Health Minister of India, who has heard that adenocarcinoma lung, lot of men are being diagnosed, and he's considered giving a targeted therapy, Prasutinib, for free to be available in all the district hospitals. Then is asked you, what is the burden of adenocarcinoma among men in India? So to look at this question, what is the burden of this disease among India? I will be appraising an article today titled Estimated Worldwide Variation and Trends in Incidence of Lung Cancer by Histological Subtype in 2022 and over time. This was published in Lancet on Feb 23 online. This is the checklist I will be using. I think you've got handouts for that. So that has 16 items. I'll be going through that. So coming to the first item, title and abstract. So does studies decide with a commonly used term, title or the abstract? So normally when the reporting is done, the study design has to be mentioned in the, this is the title. So the is a population-based study, but the type of study is a cross-section study that is not explicitly mentioned. This is a snapshot of the abstract. Here, the study design per se is not mentioned, but when you read it, you know it's a cross-section study. This is the introduction, the background, and the rationale given to explain the scientific background and the investigation which is being reported. So they have looked at the incident rate of all the lung cancer among 100,000 population before, and they said that data is available, but based on the histological subtype, what type it is, that is not available. So that's why they have done the study. So they are also looked at previous data, and they have given that based on this, we know lung cancer is a problem, but is adenocarcinoma a problem? That data is not there. So that is why they are looked at the different incidents in this study. They have also put that as a summary that histological subtype is understood. That is why the study is being done. So objectives of the study. So pre-specified hypothesis. So the first or the main objective they had was to assess the geographical variation in incidence of lung cancer by subtype worldwide in 2022. So normally in a cross-section, we cannot, because we are collecting data over one time, we normally get a snapshot or a prevalence. But here, because they have done a population-based registry study, they have looked at the new cases detected in 2020 that they have reported as incidence. So they are looking at incidence and the geographical variation by subtype worldwide in 2022. They also looked at, is there variation in this particular subtype attributable to the ambient particulate matter, that is a pollution, and they have also tried to look at the trend based on some birth cohorts, some different age groups. So that is clearly mentioned. Study design. So study design, they have mentioned it's a population-based study. It is a cross-section study when you read the methodology. And for this clinical question, to look at the variation on the histological subtype, this is a very appropriate study design. Methods and the setting. To describe the setting, location, and relevant dates. The population they have taken from 3 data sources. The main data sources is Globocan 2022 database. I will be showing pictures of that. So that has recorded data of 185 countries in the year 2022. The second place they have taken is the cancer incidence in 5 continents, volume 7 to 12, and members of the African Cancer Registry. So they have mentioned that African data was left in the other one, especially on the subtypes. So they have also looked at this African Cancer Registry to look at the subtypes for each of the cancers they are reporting. Outcome, So they looked at new cancers by gender and by age group. And all the lung cancers, they are divided into 4 histological subtypes. Adenocarcinoma, small cell, squamous cell, and large cell. So they looked at 4 main histological subtypes for CA lung. So they had described the setting, location, dates, and the follow-up and the data collection quite well. So they looked at only 1 year 2022. This was a cross-section study. There's no follow-up. Give the eligibility criteria and sources and methods of selection. So they have looked at the data and they have screened and taken all the newly reported cancer patients among the above mentioned sources. And all the patients, all the cancers, they are divided into the 4 histological subtypes. And all the patients with new CLM were included in the study. They defined the outcome. The outcome they looked at what was the histological subtype and the variation. They looked at geographical location. Based on location, is there a variation? They looked at birth cohort. So they looked at birth periods. And only for adenocarcinoma, they looked at the ambient particulate matter, the pollution factor. Now, other thing is to mention if the confounders, effect modifiers, and predictors are looked at. So here they have not tested any association. So these factors were not looked at. They have not tested any association in this study. So data sources and measurement. So each variable of interest gives the sources of data, details of methods of assessment, and describe if comparability if there are more than one group. So they have 3 main data sources. This is the GloboCat 2022 data. So it's actually available online free by you. This is the website, and if you open it, this gives we can go to the year 2022 and incidence. So they have separate data for incidence, separate for prevalence, separate for death. This is for the incidence, and this is for incidence among CLR among male. And they have given based on how much data they have. So if you look at no data, at least not there. This is not applicable, but most of the areas in the world is covered. This is for male, and they are similarly for female. So they have data among worldwide data. They have done a good search about from this registry. If you go to the website, we can actually look at incidence, and it gives a total number. It gives the ASR and it gives a total number. So this is actually for all the cancers. So from that CLM they have taken, and from that they have done the septum. This is just to show when you look at their inside. So they have gone through all the countries. Some of the countries, so 1 is good, means data is all available. 9 is some they have applied or extrapolated. So all the countries is from alphabetical order. So this so they have given it. So we are looking at incidence. So most of the countries actually in the world are covered in this. This is the second source, and this is the African Cancer Registry. So they had used this to look at the subtypes for the documented data. So the data sources were given well. 3 sources they have taken. So factors which are not comparable. So there are 3 different sources. So we do not know if they all have the same diagnostic criteria. If there were some things which were not reporting, if there are reported bias, if there are detection rates or their criteria was it same or not, we do not know. And if there are data sources which are missing, which are not reported in the registry, those parts we don't know. We don't know if they all or not. But they have taken all available sources on information on CLR. So methods. Describe any effort to address potential sources of bias. So all the data was a registry-based retrospective study. They have not reported any bias in the study or the ways they have addressed it. So they have said all the patients, all the data they have taken it. Now, sample size. So it was a registry-based convenience sampling, and they have taken all the patients, all the data which was available. Just to show example, so this is Africa. So if you go to the Africa, each country in Africa. So like that, it's an extensive list. Now methods. So what are the quantitative variables? So explain how the quantitative variables were handled in the analysis, and if applicable, which groupings were chosen. So here they have reported incidents, number of new cases, and they are reported as number of person years. They have done a calculation which is ASR, age standardized incident rate, and they reported as ASR per 100,000. So this was the main reporting of the incidence rate. They have done a trend analysis based on the geography. They have looked at a temporal analysis, and they have done something called birth cohort effect. So they have looked at people from different 5 years cohorts, and they have looked at, based on the birth cohort, is there a trend in the incidence of this adenocarcinoma. So these are the analysis they have done. Statistical methods. So describe all the methods, which so we will go one by one. So was anything used for confounding? So they have actually calculated gender specific, age specific incident rates per 100,000, and they have looked at each lung cancer based on the histological subtype and the number corresponding people at risk. So they have reported as per 100,000. They have reported by country, and they reported each by gender. So, and they have reported this incidence as ASR per 100,000. And so second trend they have done is a birth cohort effect. They have analyzed to see if there's a trend with birth cohort. So this is the analysis they did in R version 402, and they've used this program. They have not mentioned if there's any mistake data. So they have said all the data which is available, they have taken, or they have got the histological subtype with that. So coming before the results, so this was checklist we went through. The bias and the sample size, this is not applicable, but everything else was actually well explained. Explicitly, they are not mentioned it's a cross-section study, but apart from that, everything else was very well covered. Coming to the results. So this I have actually taken from the Globocon 2022 data. So they had total number of male at this much and total number of female at this much in their report. And when we actually put the same data, we get the same. So they have actually reported how much of a patient they have got, and this is actually reported, they have not missed anything. This is the way they have reported the final. This is the top row. So they have divided each cancer into adenocarcinoma, squamous cell, small cell, and large cell. Each of it they have reported as a proportion of cases. They have given the ASR, adjusted, they've given the cumulative list, and they've given for each 4 subtypes, and they have given based on each country. If you look at adenocarcinoma, they have given based on each region wise. This is a region wise analysis. They've done that separately for males, and they've done separately for females. So we will look at, this was a big table, so I had put it separately. So we will be so the adenocarcinoma was high, that was assumption. We look at adenocarcinoma, we'll look at the region wise. So maximum is in East Asia, 27.12. And South Central Asia, where we are, 3.27. Compared to Northern Europe is 11, North America is 14. So maximum was in East Asia, and this is actually for male. And they have given a similar for female. So among all the cancers, adenocarcinoma was more, and maximum in East Asia 19.4. South Central Asia, where we are considered, 1.71. So this was the main results how they have put in. The same in female. So maximum 19.4 in East Asia. South Central Asia, where we are, 1.71. The second thing they have got is the trend analysis. So this is, they looked at 2, adenocarcinoma and squamous cell carcinoma based on genders. So the regions which showed a trend, they have put it. So this are, they have given the countries they have showed. And if you look at the trend, the adenocarcinoma is actually going up, and the squamous cell carcinoma, the green line and blue line, is actually coming down, and the gap is closing. So that is what they have explained in the trend. They have done a birth cohort analysis based on the years. They have divided into cohort of 5, and they have looked at the trend, and they found that the trend has changed. From before 1960 to before to after, they found that some trend change, and they have tried to explain the discussion later. The second, one of the other objective was to look at correlation of adenocarcinoma with the ambient particulate matter. So that also they have given in numbers, ASR, based on the region where the population, we saw that East Asia was more, and they given the particulate matter that risk is more, and they given based on the nation wise also China. So this tables were in supplementary, but they've written it in the discussion in the results themselves. So among the participants, to report the number of individuals at each stage. So how many were examined, who were checked for eligibility, how many were confirmed eligible, and how many were included in the study and analyzed. So they have mentioned that all the people are reported, and each stage they have given the total number and the percentage. But the flow diagram, something they could have given, that they have not given. Descriptive data. So give the characteristics of study participants. So they have given demographic data for everyone. They have given age-wise distribution, gender, and talked about ambient particulate matter. And they have not mentioned any missing data in the whole study. The outcome data or the number of outcome events was ASR per 100,000 people, and that is how they have reported as. So this is the main result which we had seen. So give unadjusted estimate and confounder adjusted estimate and precision, that is given, and to make clear which they were adjusted for. So they have given ASR, that is how they have described their main data, that is age standardized incident rate, and unadjusted estimates, the confidence intervals they have given, and they have given the total number. Main. To describe the category boundaries where continuous variable are categorized. So here the continuous variable that taken was the birth cohort. So this was the birth cohort they had looked at, and they have divided into 5 groups. So they have actually given the boundaries for this, the time boundaries they have mentioned for this. Other analysis, if there's any subgroup interaction or sensitivity analysis, so they have done a geography trend and a gender-wise analysis. So coming to the discussion of the study, so key results. So summarize the key results with reference to objectives. So they had discussion, they have talked about how they have found that adenocarcinoma is the most common subtype worldwide, and they have looked at the trend changes. So we saw the trend that adenocarcinoma is increasing, squamous cell which is associated with smoking is reducing, gap is closing. So they have tried to explain the trend. So they have found simultaneously in that 1960 there was a change in the way cigarettes were found. It was with filter and low tar. So they postulated that people are probably taking deep breaths. So the particulate matters are going periphery. So there's a shift from central tumor to peripheral tumor. They gave probably that could be one of the cause of the trend they are seeing. They've also talked about how the cigarette manufacturing have changed. So the previously it had a lot of polycyclic aromatic hydrocarbons which are producing squamous cell carcinoma. So that has come down. Nitrosamine, which are inducers of adenocarcinoma, are more in the current manufacturing of the sector. So they have calculated that could be one. So this they have done based on the trend. So they have tried, they have explained all their findings. They have tried to explain their trend. So limitation. So you discuss the limitation is taking into account potential bias or imprecision and give the direction for any potential bias. So here they have discussed 6 limitations in the study, and I have just put 3 of that. So they said how the so population-based cancer registry, some data may not be there. Some histological subtypes they have basically done some national proxy, so that may not be fully correct. Some overestimation and underestimation might be there, so it may not be representative of the national real data. So they have actually mentioned the limitations very well, and they have discussed biases that can arise because of this. Interpretation of these results. So give a cautious overall interpretation of the results, considering objective limitations, multiplicity of analysis, and compare with the similar studies. Their study starts with, although our study findings should be interpreted with caution. So they have started with the caution. They have given an overall impression. They have compared with 2 other studies. They have given the result. Interpretation, they have done it quite well. Generalizability. So they have said that they have got data from very wide range of people. So it can be applied to any. The last part in the study is funding. So they have acknowledged the funders and they've also mentioned the role of funding source. They've also mentioned that they had no role in the study timing. So with this, we complete the checklist for the study. We will go to our patient. So our patient, being an advisor to know adenocarcinoma among men in India, coming to the study. So this is the graph from the Globicon 2022. Green is Asia. So this, they have taken data from Asia is there where we are concerned about. And if you look at this, it tells you the incidence in each countries in Asia. So this is India and this is India. So yes, new cancer incidence incidence of different types of cancer is available based on data. From that, lung cancer incidence is available and they have reported it well. And if where in India, they've even given Mumbai, Chennai, Nagpur, Pune, Barshi, Trivandrum, Dindigal, Amblikai, and Aurangabad, Northeast states, and they have written some data as projected. So overall, India, Northeast, South, and Northeast actually covered in this study. So we will take this data for male in Southeast Asia, the ASR was 3.27. Population of Indian is 730 million approximately. By putting this based on that, it comes to approximately 23,871 cases per year for male with adenocarcinoma lung. So this is the burden which we can use for the base of this. Thank you.
Thank you very much, Dr. Anuka. It was very well.